This video begins with a brief overview of health history taking, followed by general observations of neurologic status, anatomy of the cranial nerves, examination of cranial nerves 1 through 12, anatomy of the motor system, assessment of the motor system, including muscle strength, bulk, and tone, and assessment of cerebellar function, including coordination, balance, and position sense. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. In clinical practice, a neurologic examination begins with an assessment of mental status. Because the assessment of mental status relies on a comprehensive one-on-one interview, it is beyond the scope of this video. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint, along with common or concerning symptoms. Common or concerning symptoms relating to the nervous system and which are specific to cranial nerves and the motor system include changes in mood, attention, or speech, changes in orientation, memory, insight, or judgment, delirium or dementia, headache, dizziness or vertigo, loss of consciousness, syncope or near syncope, seizures, and tremors or involuntary movements. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. 3 important questions will govern your neurological examination of the cranial nerves and the motor system. Is the mental status intact? Are right-sided and left-sided findings symmetric? And if the findings are asymmetric or otherwise abnormal, does the causative lesion lie in the central nervous system or the peripheral nervous system? To enhance efficiency, you may wish to address the first of those questions here during your health history taking. Specifically, now is a good time to observe the patient's mental status, including appearance and behavior, speech and language, mood, memory, and orientation.
Okay, well, I'm going to take a look at you.
With the patient's health history in mind, you are now ready to continue your examination. Before continuing, however, let's briefly review the location of the cranial nerves within the peripheral nervous system. The peripheral nervous system includes 12 pairs of cranial nerves that emerge from within the skull. Cranial nerve 1 emerges from the cerebral hemisphere, whereas cranial nerves 2 through 12 arise from the diencephalon and brainstem. The cranial nerves mediate complex motor and sensory functions. Several of the cranial nerves are specialized, producing smell, vision, or hearing. To examine the cranial nerves, you may begin with cranial nerve 1, the olfactory nerve, which mediates the sense of smell. Typically, however, cranial nerve 1 is not tested unless a neurological problem is suspected. If you do assess its function, first be sure both nasal passages are patent.
Can you smell what this smell is?
Then, with one of the patient's nostrils occluded and his eyes closed,
Cinnamon. Right.
Pass a mildly aromatic and familiar substance such as vanilla, cloves, cinnamon, or coffee under the open nostril. If the patient detects the smell, ask him to identify it.
Can you smell that smell? Can you tell me?
Repeat the olfactory test on the other side. Normally, the patient should perceive odor on each side, even if unable to identify it.
to test your visual acuity next.
Cranial nerve 2, the optic nerve, mediates vision. To assess its function, check the patient's visual acuity and visual fields, and inspect the optic fundi.
Do you wear glasses or contact lenses?
No.
If the patient does require corrective lenses, he should wear them.
Take that card in your other
If a Snellen chart is not available, test visual acuity by using a special handheld eye card. To do this, ask the patient to cover one eye, hold the card where he is most comfortable, and read aloud the smallest print possible.
The same row of numbers?
937826.
Good.
For screening purposes, visual fields are tested by confrontation. Face the patient directly and imagine a glass bowl encircling his head. Ask the patient to look with both eyes into your eyes.
You look right at the bridge of my nose.
Then place your hands about 2 feet apart, lateral to the patient's ears.
Wiggling.
Both sides?
Slowly move the wiggling fingers of both hands along the imaginary bowl until the patient identifies them.
Wiggling.
Both sides?
Yes.
And again.
Normally, a person sees both sets of fingers at the same time.
Both sides?
Yes.
Repeat this action in the upper and lower temporal quadrants. If you think you have found a visual defect, such as loss of vision in the right temporal field,
With your right eye.
slowly move your wiggling fingers from the defective area of the field toward the better vision. Repeat this at several levels until you can define the border of the defect. Then test the other eye for an accompanying defect.
Yes.
Is it still wiggling as it comes up here?
Yes.
All right, change eyes.
Next, inspect each ocular fundus by using an ophthalmoscope. In general health care, you should examine patients' eyes without dilating their
You look
pupils.
off in the distance at a spot on that wall. Keep your eye fixed on the spot.
Inspect the optic disc. Note its color, the sharpness of the margins, and the width of the physiologic cup. Cranial nerves 3, 4, and 6, the ocular motor, trochlear, and adducens nerves, control eye movements.
Look right
Because these nerves work together so closely, they are examined as a group. The ocular motor nerve is also responsible for pupillary constriction and raising the upper eyelid. Check the position of the upper eyelids while the patient looks directly at you. The eyelids should be symmetrical and should not obscure the pupils. Next, inspect the pupils. They should be round and approximately equal in size. Size should be appropriate to room light. Test the pupillary reaction to light by shining a light on each pupil in turn. Observe for the direct reaction and for the consensual reaction. Patients with lighter irises often exhibit a consensual reaction that is seen more easily than in patients with darker irises.
Look at that finger.
Next, hold your finger or pencil about 10 centimeters from the patient's eyes, and then look for pupillary dilation in the patient's distant gaze.
Look back at the finger. Look back at the wall again.
Repeat this test if necessary.
Look at this finger now.
Next, check the extraocular movements in the 6 cardinal directions of gaze. Stand 2 to 3 feet in front of the patient. Ask him to follow your finger or a pencil as you make a wide H in the air. These movements should be symmetrical and conjugate. Look for the jerky movements of nystagmus in lateral gaze and in upward gaze. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of his nose. Eyes can usually follow your finger to within 5 to 8 centimeters. The motor portion of cranial nerve 5, the trigeminal nerve, innervates the muscles of mastication. The sensory portion of the nerve mediates facial sensation and the sensory part of the corneal reflex. To test the nerve's motor function,
Clench your teeth.
ask the patient to clench and then relax his jaw while you palpate the temporal muscles and then the masseter muscles.
Clench again.
Note the strength of muscle contraction.
And relax.
The sensory portion of the trigeminal nerve has three divisions: the ophthalmic, maxillary, and mandibular divisions. All three areas should be tested symmetrically by assessing the patient's sensation to pain, light touch, and, if indicated, temperature. Begin by explaining to the patient how you will assess for pain.
I'm going to use this broken Q-tip and I'm going to test sharp and dull.
With the patient's eyes closed,
Close your eyes and tell
test
me
for
what
pain sensation using the sterile, sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable sharp object to stimulate the patient's forehead and cheeks at the points indicated. Occasionally, substitute the dull end for the sharp one as you test scattered areas.
or different.
Compare symmetrical areas on both sides of the face. If you suspect an abnormality, confirm it by testing further for temperature sensitivity.
Is this the same as this?
Same.
Now I'm going
Next,
to
test for light touch using a wisp of cotton.
piece of cotton.
Test in scattered areas. Again, compare sides.
Now. 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 Now.
Now I'm going to compare the sides. You keep your eyes closed and tell me if they're the same or different. Is this the same as this?
Yes.
To test the corneal reflex,
And to the left.
ask the patient to look up and away from you.
The edge of your eye with the cotton.
Now, approach the patient from the side out of his line of vision and lightly touch the cornea with a fine wisp of cotton.
On this side.
Normally, the patient's eyes blink and tear. However, contact lens wearers may have diminished or absent corneal reflexes. Cranial nerve 7, the facial nerve, innervates all the muscles of facial movement and expression. It also mediates taste sensation in the anterior two-thirds of the tongue. To assess this nerve, inspect the patient's face at rest and during conversation. Note any asymmetry and look for tics or other involuntary movements.
All right. Now I'm going to ask you to perform some facial expressions.
Okay.
First, raise your eyebrows.
Next,
Strong.
ask the patient to raise his eyebrows.
Now make a frown.
Frown. Close his eyes so tightly that you can't open them.
Hold them really tight.
Show his teeth.
Relax. Now, show me your teeth.
Smile
Relax. Now smile.
and puff out his cheeks.
Now puff your cheeks out.
Normally, the patient can do these maneuvers easily and symmetrically. Cranial nerve 8, the acoustic nerve, mediates hearing and vestibular function. Because vestibular function is not routinely tested, our exam will focus on hearing. To assess hearing, test one ear at a
Now
time.
I'm going to whisper.
Occlude one of the patient's ears with your finger.
I'll start very softly.
Stand 1 to 2 feet away from the patient
As soon as it becomes
and
audible,
conceal your mouth to prevent lip reading.
Okay.
Exhale fully to minimize the intensity of your voice. And test the open ear by softly whispering numbers or words that contain equally accented syllables, such as 99 or baseball.
Baseball.
Right. Now I'm going to do a different word in this ear.
Gradually increase your volume until the patient can identify your words. Repeat on the other side. If hearing is diminished,
Right.
test for lateralization by performing the Weber test. To do this, place the base of a vibrating tuning fork
Now I'm gonna
firmly
test your
on top of the patient's head. Then ask if the sound is louder in one ear or the same in both
The
ears.
same in both ears or louder in one?
The same in both ears.
Normally, the sound is heard midline or equally on both sides. Next, compare air and bone conduction by performing the Rene test. Place a lightly vibrating tuning fork on the mastoid bone behind the ear. When the patient indicates that the sound is no longer heard, quickly place the vibrating fork near the ear canal.
Do you hear it now?
Normally, the patient can hear the sound longer through air than through bone. Be sure to test the opposite ear.
Do you hear that buzz?
Yes.
Tell me when it stops.
Now?
Do you hear it now?
Yes.
Cranial nerves 9 and 10, which are the glossopharyngeal and vagus nerves, mediate the sensory and motor functions of the palate, the pharynx, and the larynx. To test these nerves, ask the patient to say ah or yawn.
Say ah.
Assess the patient's voice. Is it hoarse? Does it have a nasal quality? Observe the soft palate and the uvula. The soft palate should rise promptly and symmetrically, and the uvula should remain midline. Then inspect the interior and posterior pillars and the pharynx. Next, test the gag reflex
Check your
one
gag
side at a
reflex.
time.
First on the left. Open again.
Using a tongue blade, and after warning the patient, stimulate the back of the throat lightly on each side in turn. You should see a prompt rise of the palate and other signs of gagging. Ask the patient to swallow.
Now swallow, please.
It should be done without difficulty or regurgitation. Cranial nerve 11, the spinal accessory nerve, innervates the sternomastoid and upper trapezius muscles. For this assessment, open the patient's gown in the back to reveal the upper trapezius muscles. Ask the patient to shrug his shoulders upward against your hands.
Put your hands in front. Turn your head straight ahead and shrug your shoulders up, please.
During this maneuver,
Hold them up.
evaluate the strength and contraction of the trapezius muscles.
Now turn your
From
chin
in front of the
my
patient,
hand.
ask the patient to turn his head to each side against your hand. Observe the contraction of the opposite sternomastoid muscle
Turn your chin into my
and
hand.
notice the force of the movement against your hand. Cranial nerve 12, the hypoglossal nerve, mediates the tongue's motor functions, which in turn affect articulation of words. Inspect the patient's tongue as it lies on the floor of his mouth.
Open your mouth.
Observe for atrophy and fasciculations. There should be none.
Now stick your tongue out.
Ask the patient to stick out his tongue. Note any asymmetry or deviation from the midline. The tongue should protrude straight out. Let's briefly review the anatomy of the motor system. Motor activity requires the combined and coordinated interaction of the cerebellum, upper motor neurons, which are part of the central nervous system, lower motor neurons, which are part of the peripheral nervous system, and the muscles. To examine the motor system, first disrobe the patient so that the largest group of muscles can be observed and examined. Fold down the patient's gown to reveal the muscles of the patient's upper torso, and adjust the lower portion of the gown to reveal the muscles of the patient's legs. Look for abnormal movements or
You
atrophy.
just relax with your hands. Right
Inspect
like
and
this.
palpate the individual muscle groups in the arms and legs. Watch for involuntary movements in the legs, or look for fasciculations or areas of atrophy. Then evaluate the patient's muscle tone or resistance to passive stretch. Encourage the patient to relax.
All right. Now you just relax. Let me do the work.
Take one hand in
Arms
yours
and hands around.
And while supporting the elbow, flex and extend the patient's fingers, wrist, elbow, and shoulder in one coordinated movement.
On this side.
The patient's arm should move easily and smoothly with little resistance.
Okay. Same in the legs now.
To assess muscle tone in the legs, extend the patient's leg at the knee and move the foot up and down at the ankle. Note the patient's resistance to your movements. Assess both legs in turn. You will grade your patient's muscle strength on a scale of 0 to 5, with 0 indicating no muscular contraction detected, and 5 indicating active movement against full resistance without evident fatigue. This is considered a normal response. In your assessment of the patient's muscle strength, ask the patient to move actively against your resistance. If the patient is too weak, test the muscles against gravity or with gravity eliminated.
First, pull towards you. Strong.
Begin by testing flexion of the biceps
Now
muscle
here.
and extension of the triceps by having the patient bend his arm at the elbow and pull, then push against your hand.
Here.
Usually the patient's
away.
dominant side is stronger than the non-dominant side.
Good. And here, push the arm out. Strong.
Next,
Okay.
test flexion and extension of the patient's wrists.
Now put your wrists up like this. Hold them up strong. Good. Okay. Now make a fist and push your wrists down. Hold them down strong. Okay. Hold that one down strong. Okay, put him down.
Next, test the patient's grip.
Now, grab
Cross your middle and index fingers to
squeeze
cushion them.
strong.
Then ask the patient to squeeze as hard as possible while you try to remove your fingers.
Good.
Normally, you should have trouble removing them.
Now spread your
Continue
fingers
testing
over
muscle
like
strength
this.
by asking the
Hold them
patient
strong.
to turn his palm down and spread his fingers. Check abduction by trying to force them together.
Good. Okay. Now turn them over like this. Touch each thumb to the tip of the little finger.
Test opposition of the thumb by asking the patient to try to touch the tip of his little finger with his thumb while you resist the movement.
Next, I'm going to test
Examination of the motor system of the lower extremities is best performed with the patient lying supine on the examination table. First, assess muscle strength in the legs. Test hip flexion by the iliopsoas muscle by placing your hand on the patient's anterior thigh and providing resistance.
You hold it there. Don't let me push it down. All right, good. Put it down.
Then test hip extension by the gluteus maximus by placing your hand on the patient's posterior thigh and providing
Now
resistance.
push it down against my hand strong.
To test hip abduction by the gluteus medius and gluteus minimus, place your hands firmly on the table outside the patient's knees.
I'm going to put my hand.
Ask him to spread both legs against your hands.
Push your legs out against my hands. Ready? Push.
To test the hip abductors, place your hands between the patient's knees and ask him to bring his legs together.
Strong.
Note the strength.
Ready? Push. Good.
Continue by testing muscle strength at the knee.
Right like this. You hold it right there. Don't let me push the foot down. Hold it there strong.
To assess quadriceps extension, support the patient's knee in flexion and ask him to straighten his leg against your hand. Note the strength and compare with the other side.
Now you keep it in that position. Don't let me push the foot down. Okay, good. Put it down.
To assess knee flexion by the hamstrings, shift your hand position but leave the patient's leg flexed at the knee.
Don't let me pull that heel off the table. Hold it strong.
Then ask the patient to keep his heel on the table as you try to straighten the leg by pulling it upward. Again, note the strength and compare it with the other side.
Keep the heel on the table. Don't let me pull the heel up. Good.
Finally, test dorsiflexion and plantar flexion at the ankle by asking the patient to pull up and push down against your hand.
Up towards you. Hold them up there strong. Don't let me push them down. Good. Now pull this foot and toes up towards you. Way up, strong. Hold them up there strong. Okay, relax. Now push this foot and toes down. And hold it down strong. Don't let me pull it up.
All of these tests can also be performed with the patient seated. In such cases, the patient may try to hold on to the table for support, but that should be avoided because it tends to disguise the true strength of the patient's lower extremities.
Now this one.
Hip flexion.
Good. Strong.
Hip abduction.
Okay. Against my fist.
Hip adduction.
There.
Knee flexion.
Good. Against my hand.
Knee extension.
Strong.
Ankle plantar flexion.
Okay.
And ankle dorsiflexion.
Hold it up strong.
To assess coordination, you'll evaluate rapid alternating movements and point-to-point movements. Begin by showing the seated patient how to move his hands so you can assess rapid alternating movement of the arms.
I want you to do like this. Over and back, over and back, over and back. Now you do it.
Observe the speed, rhythm, and smoothness of the movements.
All right.
Assess each arm in this way.
Over and back.
The patient's dominant hand may be better coordinated.
Good.
Now ask the patient to tap the distal joint of his thumb with the tips of his fingers in sequence.
Thumb in sequence. 1, 2, 3, 4. 1, 2, 3, 4. You do it.
Again, observe the movement, speed, rhythm, and smoothness.
Okay. Now with the left hand. Again, just like me doing it. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. All right, good. Now with this finger, I want you to touch my finger. Touch it. Then touch your nose with that finger. Go back
Next,
and forth.
assess point-to-point movements. Move your finger continuously so that the patient has to change directions,
Now with
and
this
observe the
finger,
smoothness and accuracy of pointing.
then your nose.
Do this several
Back and
times.
forth.
Clumsy, unsteady, and inappropriately varying movements suggest cerebellar disorders.
Now with this finger, I want you to
Then, with your finger held steady in one place, ask the patient to touch it, then raise his arm, then lower it to touch your finger again.
back down, touch my finger. Up again, back down, touch my finger. Once more, up, down, touch my finger. Close your eyes and keep doing it. Down, very good. Next,
To assess leg coordination, ask the patient to tap your hand as quickly as possible with the ball of each foot. Note any slowness or awkwardness. Compare signs. The feet normally perform less well than the hands.
hand rapidly. Okay, good. Now I want you to take this heel and run it down that shin bone in a careful straight line. Go ahead.
To test the heel-to-shin movement of the legs, ask the patient to place one heel on the opposite knee and then slide it down his shin to the big toe.
Good.
The patient should be able to do this smoothly and accurately.
In a careful straight
Note any tremor or awkwardness.
and again.
Assess both legs. Continue the examination by observing the patient's gait, which provides information about coordination, position sense, and muscle strength. As the patient walks, observe his posture, balance, arm swing, and leg movements. The gait should be relaxed and balanced, with easy, alternating arm swings. The face and head should lead the rest of the body on turns. Next, ask the patient to walk heel to toe in a straight line. This kind of gait, also called tandem walking, demonstrates cerebellar function and position sense.
All right, good. Now turn and go up on your tiptoes, like that.
Then have the patient walk on his toes to test the strength of plantar flexion,
Okay. Now walk back on your heels.
and on his heels to test dorsiflexion at the ankles. These actions also test balance.
All right, good. I'll come back to about here. Now, I want you first to hop on your right foot like this.
Next, ask the patient to hop in place, first on one leg and then the other.
Now hop on your
This ability indicates an intact motor system in the legs, normal cerebellar function, and good position
Stand on your right
sense.
foot and do
Finally, ask the patient to do a shallow knee bend, first on one leg
now on your
and
left.
then on the other. The Romberg test primarily tests position sense. Ask the patient to stand with his feet together. Normally, he should be able to maintain this posture with his eyes open, indicating intact cerebellar function. Now have the patient do the same thing for about 20 seconds with his eyes closed.
Now close your eyes and keep your balance.
His posture should remain steady, with only minimal swaying, indicating intact position sense. If the patient maintains this posture with his eyes open, but not with his eyes closed, the Romberg test is positive, suggesting a cerebellar
Now
dysfunction.
open your eyes, stand normally. Put your arms out in front of you, palms up like this.
Now check for pronator drift by asking the patient to hold his arms forward and parallel with palms up,
Keep your hands
and to close his eyes for about 20 seconds. Normally, the patient can maintain this position, but watch for downward drifting of one arm and pronation of the forearm, which suggests mild hemiparesis.
Don't let them travel.
Finally, ask the patient to keep his arms up and eyes closed while you tap the arms briskly downward. Normally, the patient's arms return smoothly to the horizontal position.
All right, very good. You can open your eyes.
A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include language such as mental status, alert, relaxed, and cooperative, thought process coherent, oriented to person, place, and time, detailed cognitive testing deferred, cranial nerves, 1 not tested, 2 through 12 intact, motor system, good muscle bulk and tone, strength 5-5 throughout, cerebellar, rapid alternating movements, finger to nose, heel to shin intact, gait with normal base, Romberg maintains balance with eyes closed, no pronator drift. To summarize, the examination of the cranial nerves includes general observations of neurologic status, an examination of the cranial nerves 1 through 12, including assessment of the motor and sensory portions. The examination of the motor system includes assessment of body position, involuntary movements, muscle bulk, and muscle tone, assessment of upper and lower extremity motor systems, assessment of coordination, Romberg testing, and testing for pronator drift.